Hey, good morning, everyone. Welcome to UroNurse. No, it's not your imagination. We are a little bit earlier today, but hey, we're always willing to be flexible. If you're watching us on YouTube, LinkedIn, or Facebook Live, welcome to the show. And those YouTubers out there, keep hitting that subscribe button. You're doing a great job. This is your first time watching UroNurse. Be sure to check out our website at uronurse.com where you can learn more about the show. Also, the best place to go to watch all of our past episodes. And we got 59 of those episodes to watch now. If you want to listen to us in your car, no problem. Check out our UroNurse Plus button. It'll get you over to our podcast area where you can listen to us on any of your favorite platforms. And hey, we've hit some milestones on YouTube. 331 subscribers. Remember, I started at 0. Not too bad. You guys are doing a great job. Over 20,000 views of our show. We're now in 25 countries. And on episode 55, I've just hit over 4,000 views for a single episode. So some really big milestones. Thanks for all you guys for making this such a success. If you're not getting our newsletter, sign up. Every Monday, a newsletter comes out with the information about the show, what's going to be next. So be sure to sign up for that. And if you're watching us live, you can always ask questions in our comments box. That's always active. And we got a great show for you this week. I have Dr. Chughtai, who's going to be talking about the iTIND. And we're looking forward to that. And now let's go ahead and bring in our experts. Experts, welcome to the show.
Good morning.
Good morning, everyone.
Good morning.
How's everyone doing today? All right. We're going to get rolling on the show here. We always do our own introductions and interesting points, facts, things like that. So I'm going to kick it off myself with my introduction. I'm Vic Sinise. I'm the host and producer of the show. Also been in urology for 40 years, which seems like it's only been yesterday. So it goes by fast. But anyway, here's my big point.
Are you ready to take your career in urology nursing to new heights? Join UroNurse for an unforgettable experience at the 2023 Urologic Conference in sunny Phoenix, Arizona, from October 26th to 29th. Picture yourself in the heart of the Sonoran Desert, surrounded by fellow urology nursing professionals, all dedicated to advancing patient care and enhancing their skills. UroNurse is calling on you to be part of this transformational event.
So yes, in case you're going to the SUNA meeting in Arizona, I plan to be there. We're going to do a UroNurse live from the conference. So be sure to join us. Come find us. I think almost all of our panelists are going to be at the meeting too. So look out for our panelists. We're going to try to do a little get together. I'll post things as we get closer, but you are a part of UroNurse. So join us at that meeting. All right, let's bring in our next panelist. Lori, go ahead.
Good morning, everyone. My name is Lori Atkinson. I am a certified urology registered nurse. I've been in urology for 25 years. I currently work for Northwestern Medicine in Geneva and Winfield, Illinois. Yes, I will be at the SUNA conference. Really looking forward to it. It'll be nice. My daughter had her baby on Wednesday.
Oh, congratulations.
9 pounds, 12 ounces, 21 and a half inches. Yeah, we were very surprised, but a healthy little baby boy, and he's beautiful. His name is Parker.
Wow, that's great.
Congrats.
Thank you.
Hey, John, go ahead and give us your introduction.
Hello, everyone. I'm a private practice, believe it or not, solo urologist in Gilbert, Arizona, who is paying it forward by sharing my experience in the business and clinical aspects of medicine to benefit my colleagues. And one of the ways that I'm doing so is by creating the Thriving Urology Practice Facebook group, where currently close to 2,400 US-based urology practice folks collaborate to improve our practices, and it's all for free. And the story I bring to you today is, well, you may recall several weeks ago, I said that I attend Friday night lights football games, high school football games at a particular local high school. And at these high school games, there's no shortage of photographers along the sidelines. A lot of them will show up with what looks like big lenses and big camera bodies. But one thing I found as I took the sidelines couple of years ago is that simply having that equipment doesn't make you a good photographer. you absolutely have to practice. And what I did was I learned from other people, other photographers who are more seasoned along the sidelines, as well as look on YouTube, read online forums, and also I read the manual. So why do I tell this story? This story is important to you because just like as in urology, your base knowledge is not enough. You need to continue to learn and learn from others who have gone before you. And I'm looking forward to learning about iTIND today, what others have done, so I don't make the same mistakes. Back to you.
Yeah, good point. All right, Lace, go ahead and introduce yourself.
Yeah, good morning, everyone. I'm Lace Heidemann. I'm a nurse and been in urology since 2013. I have been on the sidelines with thousands of BPH patients. Really excited to hear about iTIND. I currently work for the Urology Center of Iowa, also private practice. We're actually going to start doing iTIND. So really excited to hear what Dr. Chughtai has to say.
All right, great. And let's bring in our guest speaker today, Dr. Chughtai. Why don't you give us an introduction and if you have a favorite story, otherwise we'll get into your slides.
Good morning. My name is Bilal Chughtai. I'm a urologist at Weill Cornell Medical College. I've been in practice for about a little over 10 years. My area of specialty is BPH voiding dysfunction. So I specialize in enlarged prostate, incontinence in men and women, prolapse. I've published over 300 manuscripts and 4 books on these topics as well. So this is my passion. So like Dr. Lin said, I try to live, breathe, and learn as much as I can to help advance the field.
Yeah, that's great. All righty, let me bring in your slide deck here and take it away.
All right. Well, first, thank you again for having me on the show. I'm honored. So today I'm going to talk about one of the newer BPH therapies, iTIND. So as we all know, the U.S. BPH market is very large, and there's a slew of treatment options. There's everything from watchful waiting, which unfortunately I think a lot of men undergo, which they just say, hey, this is a normal part of aging, and they kind of live with this condition for a long, long time. Then we've got pharmaceuticals where we've got medicines like alpha blockers, like Flomax. We've got 5-alpha reductase inhibitors, hormonal drugs like Proscar. But we know that for a lot of patients, they discontinue these drugs pretty quickly and then kind of go, well, guess I got to live with it. We've had a surge of new minimally invasive therapies. We've had UroLift for a while, Resume for a while. Last week, a couple of weeks ago, I'm sure you've heard from my colleague, Dr. Elterman, about Optilume. We have a slew of new stents coming out. But one of the most recently FDA-approved therapies is iTIND. And then, of course, we've got surgical treatment, which go from TURP to lasers to holmium lasers, a variety of cavitation surgeries, and most recently aquablation. So what is the iTIND procedure? So iTIND is a new minimally invasive therapy that works by with no energy delivered, no permanent foreign body. So essentially the device is implanted. We could see this over the marked areas of 1, device implantation. The device is placed inside the prostatic urethra. Over the next 5 to 7 days, the device expands, creating incisions at the 12 o'clock, 5 o'clock, and 7 o'clock position. And then in 5 to 7 days, the device is completely removed, leaving nothing behind. So the device is essentially placed in the prostatic urethra in a folded configuration, and then this expands over 5 to 7 days and then completely removed. So this is just cystoscopic view. So we can see example 1 where you've got this high bladder neck, right? You can see how when you're looking into the bladder from the prostatic urethra, you can see how there's no view directly into the bladder. And after removal, you can see how there's a clear channel going inside the bladder. Example 2, we can see examples of these deep, deep grooves at 12 o'clock, 5 o'clock, 7 o'clock. And these relaxing grooves help the channel open up. We have actually, we're going to see, let me see if we can play the animation. The link doesn't work. Sorry,
I don't think that'll play.
Okay, so we'll just, I think we've got good images anyway. So the iTIND basically has got a couple of benefits for the physician where it's reliable. We've got 3 studies, including almost 300 patients. We have significant improvement with 50% improvement in IPSS, and we have durable results out to 3 years. What's really neat about the iTIND is that you have one of the first procedures that can be done with both a flexible scope and a rigid scope, and you need minimal sedation and no special equipment. And it works for prostates up to 75 grams with no middle lobe. The patient benefit is that we have preservation of ejaculatory function, preserves continence. Patients return to daily life within a few days of removal of the device. There's very rare postoperative catheterization, no permanent implant, and all future treatment options are still open. So who is a good patient selection for this? We have people who don't want to take medications, they're not receiving enough symptom relief from the medication, side effects from medications, concerns about the risks of surgery, want to preserve ejaculatory function, and want to avoid a prolonged recovery period. And again, it's designed for men who are above the age of 50 with enlarged prostate. Indications, again, we talked about it's a fit for 50-year-old males. It's contraindicated with, just like all procedures for the prostate, active urinary tract infection or prostatitis, if you have an artificial urinary sphincter or any metallic implant, any patient condition that, in the physician's opinion, may cause complication, known prostate cancer, bladder cancer, and hasn't been really tested in atonic bladder or neurogenic bladder. So common things that people ask about, is it good for the high bladder neck? I think it's the first of the minimally invasive therapies that are really designed for the bladder neck. And for prostate sizes from 25 grams to 75 grams, and those without a middle lobe. So if you look at the clinical data overview, we've got 3 large studies. We have a study from Europe, which included 9 sites, 81 patients with 3 years of follow-up. We have the study that we did in the US, which is a prospective randomized controlled trial of iTIND versus sham, 16 sites with 175 patients, 1 year of follow-up. And then we have another study in Europe with Dr. D'Annunzio, which had 5 sites and 6-month interim results. And from this, we can look at data all the way out to 3 years. And we can see that there's clinically and statistically significant improvement in both IPSS, which is obviously the patient-reported outcome, looking at how patients feel after a procedure, as well as the Qmax. And we can see that there's clearly a 50% drop in IPSS and a 50% patient improvement, and that lasts all the way out to 3 years. We have a Qmax improvement of about 50% as well, and that was durable out to 3 years as well. Now, if we hone in on the multi-center randomized trial from the US, we can look at IPSS versus in iTIND versus the sham group, and we can see that that the iTIND group had a durable improvement roughly at 6 weeks that lasted out to 1 year, and we see the same is true for Qmax as well. Now, when we compare the 3-year data for iTIND, UroLift, Resume, what we can see is that the IPSS improvement for iTIND, about 12 points, UroLift 8 points, Resume 11 points. If we look at Qmax, we have very similar improvement across the board with iTIND at 7.5 cc's, UroLift at 3.5, and Resume at 3.5. Changes in PVR were pretty similar. Again, iTIND at 60 cc's, 8 cc's for UroLift, and 26 cc's for Resume. And I think what's really, really important here is when we look at retreatment rate, iTIND at the 1 year mark had a retreatment rate of 8.6%, UroLift about 10%, and Resume at 4.4%. When you look at postoperative catheter, I think this is where iTIND really shines. We've got a 5% postoperative catheter rate, UroLift at 32%, and Resume at 90% having a catheter. So when you look at the clinical value proposition for iTIND, you've got rapid symptom relief with 3 years of durability. It's got the lowest postoperative catheterization rate of all minimally invasive therapies. It preserves sexual function, specifically ejaculatory function in men, and is suitable for those with high and tight bladder neck. And it's probably one of the first therapies that are really designed for that. And again, you're leaving nothing behind with these patients where this implant is completely removed at 5 to 7 days. Why are we choosing this procedure for our patients? Again, for those that are looking for a durable, office-based tolerated procedure that's temporary with nothing left behind.
All right, that was great. So, folks, if you have questions for Dr. Bilal, be sure to put those into the comment box. I'm going to start out with my question for you is, so what's the pain that patients are experiencing with this? It's worn for several days? Go a little bit into what patient experience is like.
Yeah. So I think there are a couple of things that get into it, right? So I think whenever we get into a disease state that's got a slew of treatment options, right? I think patient selection is a really, really important part of it. So every patient that I'm seeing that's getting a BPH procedure, I'm typically doing their cystoscopy. I'm typically doing their transurethral ultrasound. Now, if I'm doing a flexible cystoscopy in the office and this patient's jumping off the table, at that point, I'm going to tell the patient, we're probably not a good fit for an office-based therapy because no matter what I'm going to do, whether it's a UroLift, Resume, iTIND, it's going to be tough to tolerate that, right? So I'm selecting patients that tolerate flexible cystoscopies pretty reasonably well. The second thing is I do tell patients up front that this is a device and this device is expanding within the prostate, right? When we first put it in, you're going to have local anesthetic in. You're not going to feel much. But after a couple hours, you're going to start feeling it. So I'd have these patients start with either Tylenol, Motrin, Pyridium almost right away. I also tell patients that, if we need something more, like we have to add on some like Valium suppositories, if we have to add on maybe like a Medrol dose pack, I'm here for you and I'm going to help support you during that time. And in the worst case scenario, if for some reason you can't tolerate this device, I will take it out early. So we start off with that conversation. I want them to know that, this is a procedure where you are going to be aware of the devices in there. But my experience has been that every patient I've done so far has tolerated the device for the expected amount of time.
And what is that amount of time that it's normally left in?
It's usually 5 to 7 days.
We have a question from Susie Swain. So what are the restrictions for patients post-procedure and for how long?
So for restrictions for the procedure, when you have the device put in, the iTIND is in place and there is a string that hangs out of the penis, right? So during that time, patients they do limit themselves quite a bit. The biggest restriction would probably be avoid bike riding and avoid putting pressure on that perineum, as well as avoid sexual activity while the device is in. After the device is removed, I still tell patients to avoid sexual activity for about 2 weeks, just because I feel like that's what we've done with every BPH procedure.
Great. We also have a question from Glenda Wilkinson. How many patients have you now treated with iTIND?
I think now I'm approximately at like 50 to 75, probably 50 to 60 patients right now that we've treated with iTIND.
Yeah.
Sorry. Go ahead.
Oh, sorry. Dr. Chughtai, I did have a question. So one thing that I think it's really interesting about this minimally invasive approach to treating BPH is that one, it appears you can do it in the office with a flexible cystoscopy and whatnot, and that there's lower rates of post-procedural catheterization because no one wants a catheter, right? Say someone overnight can't pee, right? They go into the ER. They have a string hanging out of their penis. This might not be something that the ER folks know about. How do you handle situations like that? Because I'm assuming, just putting in a regular catheter, I mean, how do you handle that?
Well, first of all, none of my patients go into retention. No, totally kidding. But what I was going to say is that you're right. So with these patients, a lot of times you're right. We've got the string hanging out of their penis if they're not able to urinate. So every patient I try to check, obviously post-void residuals, I check a uroflow in the office, but you cannot predict every patient who may go into retention. So for these patients, I do tell them that if they need a catheter placed, that it should be done from a urologist, right? And I'm a little bit lucky in that I live approximately 3 blocks away from the emergency room. So if one of my patients who I did iTIND on went into retention, I would just go in myself, right? But essentially placing a catheter around the iTIND, the cage of it is fairly large. So what you would do is essentially you just need one person to hold the string so the string doesn't end up inside the penis, right? And as long as you hold the string, what's going to happen is that a 14 French catheter is going to slip right through the cage of the iTIND and the catheter can stay in place during that time. I would say that's the only caveat, that a Foley catheter, which is usually a one-person operation, now becomes a two-person operation where one person is holding the string, the other person is advancing the catheter.
Yeah. Would you then, have that person follow up in the office to make sure that there's no dislodgement, of the device? I mean, I guess that's another question. What if accidentally that string gets pulled, on, because I don't know. I assume, is it taped to the penis or?
So there are a couple of different ways of doing it. I think one way that we commonly do for ureteral stents is that we would tape the device to the penis. I asked the patient. I mean, I have some patients who are kind of like, I don't want something taped to my penis, and I'll leave the string hanging, like sort of like it's a single string hanging. The thing about a ureteral stent is that one tends to be a loop, and loops are easy to catch on stuff, but single strings typically don't get caught on things. But if for some reason the patient decides to cut the penis saying, silly doctor, you left a string in my penis, I'm going to cut this, right? If that were to happen, then the workaround is you have to use a rigid cystoscope. And when you use a rigid cystoscope, you go in and grab the base of the iTind and it collapses within a 22 French cystoscope.
Okay. Got it.
Okay,
Thank you.
have a question. Thanks. We have a question from Katie Bortel. She wants to know any problems with bleeding.
So right now with bleeding, what I've done is every patient, we stop anticoagulation. So as a result, I have not had issues with bleeding. Because essentially what you're doing is you're creating areas of ischemic necrosis, right? So if we think about the bladder neck, you have an area that you've got a device that's pressing on it, but also cutting it. And it's pressing right where the blood supply for the prostate comes in as well. So essentially, as it cuts, it's also putting pressure on that area. So as a result, the bleeding has been pretty minimal so far.
Great.
But I haven't tested the system by doing like patients on like multi-anticoagulants.
Sure. And we also have a question from Susie Swain. If patient comes in with indwelling catheter, will they wear catheter post-procedure?
Yeah, so the answer to that is sometimes. So remember, I'm still, I would say, early in my experience. I still don't have like over 100 patients treated. But I've done a handful of patients in retention. I've had probably half where I placed the iTind in place, and once it was in, the prostate was propped open enough and had enough good bladder function where they were urinating immediately after the iTind was placed. Fortunately, those patients actually lived very close to my office, so we actually left them without a catheter with the iTind in place. I've had the other half of the time, I actually placed a 14 French catheter right after the iTind was placed, and therefore the catheter was placed. And what I did was I also did a ultrasound at the same time afterwards, just to ensure the fact that the iTind was within the prostatic urethra.
I have a question for you, actually. Do you immediately stop alpha blockers if they're on them afterwards?
So I don't stop alpha blockers for about 2 weeks after any procedure. My logic is that once this iTind is out, or once you've done any procedure, there's going to be a period of time where there's post-operative irritation, swelling. So I keep alpha blockers going for 2 weeks. There's no data to suggest one way or the other, so I've always kept that on. Dr. Lin, what do you do in your practice?
Oh, anytime I do a UroLift, iTind, TURP, I immediately stop alpha blocker and 5-alpha reductase inhibitor because the visual change is so huge. I'm thinking, why do I continue patients on a medication? So I immediately stop these medications. And to circle back on, this iTind procedure, it's great that we have another option. Tens of millions of men in the US suffer with BPH every single year. It's a huge market. That's why there's an influx of procedures concentrating on the management of BPH. Heck, my prostate is getting bigger as I approach my 60s. So it is a big market. A lot of people are jumping into it. And as always, I look at it from clinical efficacy, whether there's legal acceptance, and of course, iTind passed those two. But the biggest hurdle for me in using iTind is financial, meaning coding and billing. So if you can discuss that a little bit, Dr. Chughtai.
Yeah, so coding and billing is a very complex topic altogether. because what's hard is that when a procedure first comes out, and I think Resume had this, UroLift has this, it's really hard to bill and code for these because you're using an unlisted code. And a lot of insurances are very challenged because they'll say the data is inadequate. And it's almost like a circular argument where they need more data, but there's also very low utilization because it's an expensive procedure. So between the two, it does become a bit challenging. And I'll tell you, New York is a challenging market where insurances are reluctant to pay for novel, even though proven procedures. But I think it's, I think iTind is on its way to try. I mean, like the Olympus has done a good job to sort of address these things and come up with a variety of mechanisms to help this occur. There is a current code for the ASC, so the device is reimbursed. So they do have some of those things that are helping with that. But I agree with you, Dr. Lin. It is a hugely challenging area of medicine where you have a patient in front of you and you're like, well, TURP is covered, laser's covered, Resume is covered, UroLift is covered, but this thing may cost you X amount of thousands of dollars, and that does become challenging.
So just to make sure everyone understands, if the procedure is done by the physician would use an unlisted CPT code. So everything that we do in medicine, there's a code assigned to it. Almost all things we do, there's a code assigned to it. When you have a novel procedure, then you use an unlisted CPT code. And billing or getting paid for that particular code is challenging. Thankfully, iTind or Olympus that acquired iTind has an excellent support staff that will help you navigate the pre-authorization process. Unfortunately, insurance companies I like to say they deny, decline, delay, and deceive. So just this week, I had 2 iTinds denied by insurance companies because it's experimental.
Dr. Lin, could you tell us what you really think about insurance companies?
Well, let me tell you how much of a that they are.
Yeah.
But I would agree. It does become a huge discussion point and challenge, and it's something I tell patients up front, because what'll happen is that when patients get that discussion of, hey, you may have an out-of-pocket expense, then all of a sudden, then the patient becomes a little bit like, wait a second, is this experimental? Is this approved in the US? You're like, no, this is a FDA-approved procedure. It was approved in 2020. But unfortunately, the way there's FDA approval, and there's a whole financial part of it that goes with insurance companies. And that's another part of the discussion.
Yeah, it takes a while to catch up.
I will say from a nursing perspective as well, so for all of you nurses out there that are side by side with these physicians, seeing the patients and doing UDSs and various different tests and making sure that they have all the paperwork, which sometimes seems tedious, right? Filling out an IPSS score sheet and whatnot. But know that you are a huge line of defense to assure that when it is that we come upon a denial or when we're looking for a prior authorization, you want to make sure you have all your T's crossed and your I's dotted, right? So prior authorization, you want to make sure that you're checking with companies like Olympus, who's your perfect candidate. The physician obviously selects that, but all of your staff should be aware as well, right? I mean, as we all know, different BPH procedures, you can't have certain allergies for UroLift, for Resume. There's age restrictions, or you can't have prostate cancer, or this or that. And you want to make sure it's well documented. Sometimes it's as simple as asking the patient a question and putting that in the note in the chart. But you want to make sure that you have that covered, because prior authorization doesn't mean you're going to get paid. And so, it's really, really important, which actually brings me to a question, Dr. Chughtai. What is iTind made of? And is there an allergy restriction?
Good question. So iTind is actually made out of a novel material called nitinol. So nitinol is a combination of nickel, titanium. And what's neat about it is that it was actually discovered in a naval lab where basically this compound was dropped on the floor and it had a very unique sound. And the best way to describe what iTind is like if we were to design like a slinky, like a toy that we've all had like when we were kids, right? iTind is like the perfect slinky where it always remembers its shape, right? So essentially when you get this device delivered, it's crimped, it's tiny, right? And then once you take it out of its sheath, it remembers its original shape, right? And what's neat about it also is that depending on the temperature of the fluid, so if you're running in cold or saline, the nitinol is actually far more flexible, right? And then when it comes to room temperature, the nitinol actually becomes much more rigid. And that's what allows it to cut so well at body temperature.
Interesting.
We have a question from Susie. How much is the procedure?
Yeah, so right now it's more of like, well, getting back to our favorite topic of insurances and coverage, it depends, right? So essentially, there's going to be a facility fee that that would occur if you are in the ASC or the hospital. Then there's also in the office, there is no real code for it, so use an unlisted code. The device itself is, I think it's roughly around. I want to say roughly around $3,000. I don't know the exact amount. I'm sure it varies from region to region. And then there's going to be a separate physician fee. And I think there's a second question about the CPT code. So there is no current CPT code for iTIND.
And then Olive had a question. She works in a hospital setting, and all removed ureteral stents are sent to pathology for gross examination. Do you send the removed iTIND to pathology for gross examination?
So in the office, we have not been sending the iTIND for gross examination because of the potential cost to the patient. If there was any doubt of any retained foreign body, obviously we would send it. I think a lot of hospitals in the operating room setting will require the full stent to be sent. But right now in the office, we have not been sending the iTIND.
Wait, okay, hang on. It's only in extremely rare instances where I would send a removed stent either in the office or actually, I don't think I've ever sent a removed stent in the office to pathology, but maybe once or twice in the hospital. So this is being done. I mean, This is off topic. This is being done routinely. You remove a stent in the OR and then that is being sent to pathology for gross.
So Dr. Lin, that's normal. I mean, I would tell you even when it comes to sacral nerve modulations, like our stage ones, we send to pathology. That's the way it's done.
Wow, that's why healthcare costs so much money.
Yeah, I just imagine the pathologist looking at it, going, "Aha,
it's a stent."
It's intact.
I simply document that the stent was removed transurethral. Inspection of the stent removed showed that it was removed in total. I dictate that in my op report.
Yeah.
I don't know.
I have a different question to ask. Could you kind of take me through what you would tell a patient? They're again, the experience of somebody who might go through one of these procedures. What would I expect as far as anesthesia to place this, how it's placed, and then removal? What anesthesia would I receive after or to have it removed? How is it removed?
So when I first started doing iTINDs, we were actually doing it under sedation with a rigid scope. Then we switched over to a flexible scope. With the flexible scope, I was actually doing the same protocol that I do for a Resume or a UroLift, which is a prostate block, and then doing the procedure with local anesthetic, right? And also giving a Valium. Then what I realized with iTIND, what was happening was that all the Valium did was make them sleepy after the procedure. It didn't change much for them for the procedure itself. So for iTIND now, what I've been doing is we do lidocaine jelly inside the penis, clamp the penis for about 10 minutes. After that, we put the flexible scope in, and then I put in lidocaine inside the bladder. At that point, we do the procedure, and then that's it. That's the total anesthetic we've been doing, and patients have been tolerating it well. But also keep in mind, I am highly selecting patients, right? If you can't tolerate a flexible scope that I do in the office, you're not getting an iTIND. So I don't want to sit here and tell you it's a walk in the park, but I would tell you for the patient who tolerates a flexible cystoscope well, they can tolerate the iTIND almost it's like neck and neck. I would say it's a little bit different for other minimally invasive therapies where, the procedure itself is a lot more uncomfortable than a flexible cystoscopy.
We have
no prostate block on, excuse me, no prostate block for the insertion
removal
anymore. Is that correct?
No, removal is actually, I just put lidocaine inside the penis, clamp the penis for 10 minutes, and that's it.
No, I mean for the insertion, did you quit using the prostate block
I stopped using prostate blocks.
Oh.
Okay, we have a question from Tyler Steele. How do you factor in the high loss to follow up in iTIND clinical studies?
Yeah, so that's actually a problem in a lot of benign urology altogether, is that unfortunately, we have this concept called like regression to the mean, which basically means that the people who did really well are like, I'm good, I'm never coming back. And the people who did really bad go, that didn't do so well go, that doctor sucks, I'm going to someone else, right? So as a result, we end up losing a lot of the extremes. And there is a high loss of follow-up in almost all BPH studies from every minimally invasive therapist to iTIND itself. And I think when we look at the data that we do have, the data does look good. But you're right, like we don't know how those patients did. We don't know if they had subsequent retreatment, and that is a limitation of the data set. It's actually one of the things I'm trying to work on is actually studies now that we're doing. We're trying to see the role of like, can we use like mobile apps or other ways to follow these patients just to get an IPSS or just to get something like down the road, like 1 year, 2 years, where they just go, I'm good or not so great, just to get an idea of how these patients are doing down the road as well. Because to have them completely lost is different than having at least some limited information.
Yeah, we have a question from Glenda Wilkinson. How long does it take on average to implant an iTIND? How long is the removal?
So the implant itself is fairly quick. I would say about 2 minutes to place. And if you guys want, I can actually show you a video that we've made of me implanting it flexibly in the office as well. So I can definitely share that.
You could bring that up on your screen share if you want.
Yeah. So why don't I do that? And removal is probably around like 30 seconds to do. It's a fairly quick thing. Let me just go ahead and share the screen.
I'll just comment that removal requires a considerable force by the urologist or whoever is removing the iTIND device. So keep that in mind.
Yeah, but I would also say, like, Dr. Lin, like, I think the force is, you're right. It does require understanding of the fact that you are doing a push-pull maneuver, and that push-pull maneuver is against the iTIND to cause that iTIND to collapse back in. And if you exert the same amount of force on the iTIND without it collapsing, I agree. It can be quite uncomfortable for the patient.
Well, one of my first patients somehow self-removed prematurely his iTIND, and he did great. Yeah.
Did you tell him to? No, I'm kidding.
No, we gave him excellent instructions.
It's a strong string, I take it.
Yeah. Oh, yeah. String is extremely strong.
We don't need the music.
You got to go to this present screen share. So I get your screen share to come up.
Oh, sorry, 1 second. I thought it's on screen share.
And while we're waiting, I'm just going to say, Olive asked, what is the CPT?
I just found it. There we go.
Is it on? Okay, perfect.
Yeah.
All right, so here we're just doing a routine flexible cystoscopy up to the sphincter right here. And now we're going past the Vira Montana. We've got lateral lobes of the prostate. We're in the bladder. Following this, local anesthetic is placed right through the scope.
How much are you putting in?
About 60 cc's, and there's two purposes behind it. One is numb the lining of the bladder, and two, to give the bladder enough room so the iTIND, when it expands in the bladder, it's got space to be in there without like irritating the patient. So here's all the components that you need. Here's a flexible guide wire going inside the scope. And then here you're doing a push-pull technique to just leave the guide wire in place. And you can see how critical the nurses are for this procedure. Like, you definitely need a second set of hands. And here you put a ureteral access sheath right into the right over the guide wire, and you remove the inner lumen. So this is a 1214 ureteral access sheath. I usually bend this, sort of like shape it like a coude tip to help it get past the prostatic urethra as well in the high bladder neck. And here's this collapsed iTIND. And this is placed directly inside the ureteral access sheath that fits right in. And there's a blue line on the iTIND that tells you what position you're in as well. So it tells you how you're oriented. The ureteral access sheath is then removed, and a flexible scope is in place alongside the iTIND. Here, what's really helpful is having like an additional person in the room, like especially when you get to the prostatic urethra, just to squeeze the bag so you can get good visualization. And all you're doing is confirming, like you can see here, you're just confirming that the iTIND, the portion of it that's the loop, it kind of looks like a duckbill, and it just sits distal to the bladder neck. Once you confirm that it's in position, you just remove your scope and the procedure is complete. And it does take roughly around like 2 to 3 minutes once you get started to do the whole procedure. At this point, you just cut the slip knot of the iTIND string, removing its guide wire. And at this point, you can make a decision if you want to either tie it to the penis or leave it hanging. And we can see here the iTIND when first placed in, then the iTIND in the second figure, the iTIND fully expanded, and the third figure when the iTIND is removed.
Yeah, that was great.
Yeah. Dr. Chughtai, what are some instructions that you send home with the patient? You know, as we all know, is it going to be normal to have urinary frequency, urgency? Will they see blood in the urine, etc.?
Absolutely.
When should they call?
Yeah. So what I usually do is when we schedule the iTIND procedure, I give post-op instructions right then and there. And the goal behind that is I want to set the expectation, right? I want to set the expectation that, you know, while this device is in, you are going to have urgency, you are going to have frequency. Expect to see some blood in the urine. You see urine that you cannot see through, I expect a phone call, right? Any fevers, chills, flank pain, I want to know right away. So we do give those instructions right up the bat. And I think it's also helpful to give them ahead of time because patients will sometimes, when they get them on the day of the procedure, they're sort of like, there's a lot going on that day and they sometimes don't go through it. But I find if you give it ahead of time, it's helpful for them and they'll actually read through it and go, well, am I really going to have to wear a diaper? I was like, you may, right? Because that string will literally wick some urine outside the bladder. And some patients do require a pad for a couple of days after the procedure.
Sure. Yeah, no, I agree. I agree that informing the patient ahead of time is great. We do the same in our office. We actually have created procedural packages and surgical packages that talk about what is this, what to do before, what happens during, what to expect after. And patients really do enjoy it. They read it.
I do it beforehand.
With that scope, if it's not in the right spot, is it something you can readjust or is it take it out, start again?
You're talking about with the iTIND itself, right?
Yeah, iTIND, yeah. You look in with the scope and now you see it's not where it should be.
Yeah, so what I find is that if you can take that iTIND, pulling it back into position is a very natural maneuver for it. Pushing it into the bladder becomes actually quite challenging. And sometimes what you might have to do is that you may just have to while the guide wire's in, you have to gently push it in. And sometimes you have to nudge, like with your scope, the bladder neck and just get it over. Once you get it deployed back in the bladder, it's very easy to put back. So typically what I try to do with the iTIND and the scope is I try to move them in tandem. So I'll park my scope right at the bladder neck itself, right? So I'm looking at the iTIND, I'm looking at that, basically that retaining loop on the bottom. And with that retaining loop, I move the whole thing in block back and make sure that the retaining loop is just distal to the bladder neck. Once that's done, I confirm visualization, we're done with the procedure.
Oh, good. Well, it's been a fascinating talk. I really appreciate all your information. I think we learned a lot from it. Any other questions, please put them into the Q&A box. Panelists, if you have any other comments or questions, this is your big chance. Otherwise,
sure.
Quick question.
Yeah.
How long do you schedule these for in the office? Obviously, you know, the portion of the physician, very quick. But we know that the patient's going to be there a tad bit longer than 10 minutes. So how long do you schedule these for?
You're right. And I think that's something we actually didn't do a great job of covering is that you're right. There's the whole process, right? So I would say that average patient, I'd say around like 45 minutes to an hour, because what's going to happen is patient's going to come in, they're going to change into a gown. We're going to put local anesthetic in. You're going to clamp the penis for about 10 minutes. And you're right. Physician comes in, we do our thing. And then after that, we're out the door, right? And then at that point, then obviously patient has to feel like their bladder's full enough. They're going to have to empty. Also at that point, you know, our staff is amazing at ensuring the fact that the patient may, you know, if there's any pads that they need, ensuring if there's any bleeding, we account for all that stuff. So the full time's probably about an hour. I tell patients like, you know, feel free to linger and stay around. If you have any concerns, you know, we'll have them come back as well.
And John, you had something?
Yeah, Olive asked, what is the CPT code for iTIND? There's currently no CPT, as Dr. Chughtai said, but you would have to use an unlisted code, and you would link that unlisted code to a known procedure, such as the initial implant of a UroLift device, and then you use that cost or the price, you link that price to the unlisted code. Now, if you were to do this in a surgery center or the hospital, for the hospital or the surgery center, there is a C as in Charlie code that they can use to submit for payment. And that actually, the ASC in the hospital or the facility code, their payment is actually quite good.
And also, Dr. Lin, just to add, there is no physician reimbursement for that setting. It's only for the facility. So you're back to using an unlisted code for the physician.
Oh, yes, of course, of course.
Yeah. I think it's pretty, common for all of us that have worked with any new procedure that once you're using unlisted numbers, it's kind of a roll of the dice is the coverage.
Yeah, and I also find that for a lot of patients, once you explain, not the nitty gritty, Dr. Lin, you've done a great job of the nitty gritty of CPT versus the C codes, but I usually tell them up front, this is a relatively new procedure. This may or may not be covered. Go in with the expectation that there is going to be a cost, right? And I also tell them hey, this is the number of procedures that I've done. I also tell them hey, this is the data that we have, and here's the absence of the data. So a lot of times patients will go, you're giving me 5 years worth of data on UroLift, 5 years worth of data on Resume. Why are you giving me 1 year and 3 year experience on iTIND? And I go, well, I'm not telling you that it doesn't work at 5 years, but I'm telling you we don't have that data.
Yeah. All right. Well, very good. I'm going to go ahead and bring in our, once again, thanks everybody for all your effort and time. We do have a little plug for next week. Next week, we're going to be talking about urology imaging.
In the realm of urology, the saying, "A picture is worth 1,000 words," couldn't be more apt. Urology imaging plays a pivotal role in diagnosing and understanding various urological conditions. These images, captured through cutting-edge technologies like ultrasound, MRI, CT scans, and X-rays, provide invaluable insights into the inner workings of the urinary tract and reproductive system. Whether it's detecting kidney stones, assessing the size and function of the prostate, or identifying tumors and blockages, urology imaging empowers healthcare professionals with the visual evidence they need to make accurate diagnoses and formulate effective treatment plans. Check out episode 62 to learn more at UroNurse.com.
Yeah, we hope everybody joins us next week to talk about that. This was actually a subject that was sent in through the contact us button on the UroNurse website. So if you got a suggestion, you want something for us to talk about, we'll be glad to honor those. And again, everybody, thanks for all your input and your time. Dr. Chughtai, that was great presentation. Really appreciate you coming on and joining UroNurse. Hope you'll check us out in the future.
Will do, and thank you again for having me. I really appreciate it. I really enjoyed the conversation.
Yeah, thank you. Well, goodbye, everybody. Have a great rest of your weekend. Enjoy that sunshine if you've got it. And we'll see you all next week.
Thank you. Have a good weekend.
Hi, everyone.
Bye-bye.